Well, it's really nice to be back here again. As Don said, I'm Sid Soderholm, and I was here a few years ago and very much enjoyed that. NORA has many parts. I'm only going to talk about a little bit of it today. If you ask a researcher in NIOSH what NORA is, most of them will say it's an internal grants kind of competition that we have to fund internally research that advance the various objectives of the National Occupational Research Agenda. And if you ask some of the people internally and others, you'll find that the main focus of NORA for them is the NORA sector councils, and I'll talk about that a little bit. There's also in the R01 or in the grants process for extramural researchers, for people who aren't in NIOSH, there's an exhortation to take a look at the NORA priorities to see if any of those fit into the kind of work you want to do and maybe give some direction or some ideas of partnerships. And then, of course, there's Congress. We get our funding from Congress, as the federal government does. And they have a view of NORA, a new way for a research agency to try to accomplish its mission. And certainly, not the least, is this type of effort. Several years ago, I think it must be over 15 years ago now, when there was kind of NORA money coming from Congress, kind of colored NORA. It had to be tracked as NORA, and some of it went out to the ERCs for NORA funding, and several of them, and I'm not sure how many continue now, did a process of small grants that have led to other regional symposiums like this. So there are many, many different kind of sides and pieces of NORA. And one of the things, one of the reasons I like to be called NORA coordinator rather than director is that, you know, at most you can coordinate. There's a lot of work going on, a lot of people being involved. So one of the catchwords of NORA has always been partnerships from the very beginning. When Dr. Rosenstock, our director in the mid to late 90s, started this concept of a National Occupational Research Agenda. It was actually a time when there were some voices on Capitol Hill saying, we don't need NIOSH, why are we funding them? We've got OSHA, and they do the same thing, don't they? And so Dr. Rosenstock, of course, needed to educate Congress about what we do, and one of our approaches is to focus on partnerships, that we are meeting our mission by talking to, listening to, and working with the stakeholders that we claim are part of our mission. Certainly there's the workers, that's the ultimate focus, but the community of occupational safety and health that is out there in corporations, teaching in universities, and all facets of the community, we're working with them, and we aren't just here in our own little governmental ivory tower doing what we think needs to be done. So that's why partnerships became an important word early on. Let me take a guess, there we go. So at the very beginning, the NORA was advertised as having two pieces. It was always called a partnership effort, and we're defining and conducting priority research with the stakeholders. So that was the vision for NORA. And we use partner in a lot of ways. I've been kind of called by one of the engineers leaders in NIOSH several years ago. You guys call everything a partnership. Don't you know what a partnership is? Well, we do use the word partner very loosely. If you come to a public meeting and give some input as to what you think the priorities are, we're going to call the group of people who came partners of NORA. But we do know what a partnership is, and a partnership has some very specific characteristics. And in the NORA context, we talk about a group of people who are coming together. They've identified a risk, or they've identified some potential solutions, But in order for this group to coalesce and accomplish anything, they need to have one or two, typically, champions. Who's going to call the meetings? Who's going to celebrate the successes? Who's going to say, wait a minute, we didn't get done what we said we're going to get done in the last year? And a partnership needs to get all the relevant stakeholders at the table. At least invite them. Not everybody's going to come, not everybody's going to stay, but make them aware that this effort's going to go on. And hopefully a large cross-section, a good sample of them will stay and help with the effort. And this partnership, as it develops, needs to understand what its shared values are. Everyone who comes together in this kind of partnership is trying to decrease the burden on workers. But your next highest value, if you're corporate or union or government, might be different. So we really need to understand what the shared values are. What are we trying to accomplish? How soon are we going to try to do it? Who's going to be involved? And then we have to develop either new knowledge or develop products. Typically, if we're going to deliver products, we have to make sure what the audience is. The members of the target audience have to be part of the effort. We need a marketing plan. A lot of partnerships are at this end of the spectrum, getting information that is known out to those who need to act on it, really, for workers to benefit. And then you have to track progress, refine your plans, celebrate, and in the NORA context, if you've got something going well, talk to everybody else in NORA about it so we can benefit from what you've learned. So we do know what a partnership is. Even though we use the word partner very loosely often, we do know what a partnership is, and if you haven't thought about it, I would suggest these are some of the key elements that you might want to keep in mind, because, gee, this computer's almost on the floor here. Okay, because most of us at one time or another, whether it's 2 people or 40 people, are going to be involved in getting our work done through partnerships. Try to figure out how to get things arranged here. So in the first decade of NORA, which was basically from, we usually counted it from Workers' Memorial Day, April 28th, 1996, for the next 10 years, Dr. Rosenstock and the leaders of NIOSH and the leaders from outside of NIOSH she was talking with had a series of meetings, and by the beginning, by April of 1996, they defined 21 priority areas. And these were a broad range of priority areas. 2 of them were actually combined, but most of the priority areas had a team. And this team had a co-chair from within NIOSH and a co-chair from outside of NIOSH. So again, we're trying to cement this partnership. And they talked about what needed to be done. So this is things like occupational skin diseases, intervention effectiveness research. It was just a whole, 21. And I've spared you the list this time, trying to get to the main story, talking about partnerships. Some of the successes of that first decade were joint funding of research successes. If you were if you were a university researcher at that time, and you would have found that NIOSH and the arm of NIH that deals with dermatitis and skin diseases did a joint funding announcement for a couple of years. So this, we got NIOSH extramural budget for researchers, and we've got NIH's extramural budget. So to attract some of that to complement work that NIOSH is able to fund in occupational safety and health, skin research in this case, was a real success. And so there are several examples of that. That's one kind of partnership that happened agency to agency. But there are also a lot of public-private partnerships. And we've highlighted those in various ways. And if you're interested in history, there's some information on our website. But I'm particularly going to talk about a couple of award-winning examples of positive impacts on workers that happened, or partnerships that were particularly successful in the first decade. And these went on for a decade or more. In fact, both of these are still going on. The first one I'm going to talk about is asphalt paving partnerships. Now this was actually a series of partnerships, but the common element for it was the National Asphalt Paving Association. From, I would say, probably 1992 until pretty much this year, they've been key in a series of efforts. And the report on the left is to remind me to talk about the first major effort that came out in 1997, this report did. And this was a culmination of several years of work when unions and manufacturers of these big paving machines and contractors and government agencies got together and each brought their own expertise and were able to take the asphalt fumes that were just billowing up around these workers day after day in my part of the country during the summer and maybe in some parts of the country year-round. And they basically did a local, I guess, for a big machine, exhaust ventilation system and spewed it up into the atmosphere, which on our environmental side we have to worry about a little bit, instead of spewing it into the lungs of those workers day after day. So this took a big effort. The unions brought certainly a desire to reduce these exposures. NIOSH brought ventilation expertise, but also industrial hygiene expertise in this moving laboratory of a paving machine. How do you actually prove the exposures are lower? And so NIOSH brought that expertise. The contractors made work sites available and machinery available. And the manufacturers of these machines, and there are only a couple of manufacturers in the US, actually, of course, they have their research arms. They decided to become interested and see if this safety and health aspects of these huge machines could be a selling point. And they would, take the information from NIOSH about in general how this ventilation could work, and they would go back into their labs, their warehouses, and try some things. And then they'd actually ship something halfway across the country to a work site that NIOSH and the Pavement Association have been able to arrange to have this tested. And of course, that's probably a $100,000 shipping fee right there. So they brought a lot to it. And in the end, the exposures of the workers were much lower. The next thing I don't really talk about is that the next phase of the partnership, they talked about warm asphalt paving instead of hot asphalt paving. And that actually reduced the emissions to the atmosphere drastically. So that helped both the workers and the atmospheric emissions issue. And then the last thing, the report on the right came out this year, but it's again been about a decade-long effort in what happens before you pave. The thing that you do before you pave is you mill off the concrete and the old asphalt, and so it's almost always concrete underneath, so you've got your silica exposures you're getting into. So you mill that down into a reasonable surface that you can then pave. And so the milling machines, again, a decade effort, different manufacturers, again, ventilation, industrial hygiene measurements in this moving laboratory, and putting that all together had great success in reducing these exposures. So partnership takes a long time, have the right people at the table, but it can make a big difference for the workers. The second one I'm going to talk about is the hazardous drug safe handling work group. This actually came out of 2 of our 20 NORA teams in the first decade, reproductive health and control technologies. And there were reports coming out that if you bothered to look at the outside of the vials of these anti-cancer drugs that were being, very toxic material, very toxic drugs that were being administered, you found that there was a shockingly large amount of the anti-cancer drug on the outside of the vial. So this goes all the way from the manufacturers to its handling, the countertops where these things were prepared for administration were just covered with these very toxic drugs. And so that was becoming known in the mid to late 90s. And so a group saw a need to address this. There had been some guidelines, but people really hadn't kind of picked up on this. So there were 45 different individuals and organizations who participated. They developed best practices, and I think this might be the first time that a NIOSH alert, which is a pretty highly recognized document, a NIOSH alert was co-authored by people outside of NIOSH. So this had a large number of co-authors. And this alert from, did I write down the year? Excuse me. This alert in 2004 is still being cited in new state laws about how hazardous drugs have to be handled in clinics and hospitals. It's being cited internationally. And this large group that came together wrote this alert, then really worked on getting it marketed out to those who needed to know it, and it included a list of the drug by this name. You have to handle it according to these guidelines. This is toxic enough to be handled this way. So that's going, and they don't have any regulatory authority. This is all guidance. This is all professional opinion. But you look who's behind it, and if you're an employer who has one of these sites, and the law says that you have to make reasonable attempts to keep your workers safe, you can't really ignore something like this any longer. So it's become written into Merck handbooks, into chapters of the Merck handbooks. So this has really taken off. It came together with 45 people who said, this is terrible. We've got to get the tools out there and get people to use them. And out of that professional concern, they've moved forward. The list of drugs, because drugs are always changing, the list of drugs have been updated, the 2012, 2014. And this is getting more and more attention. So these are 2 really successful partnerships, decades-long work. We're talking about devoting a fair fraction of one's career for the leaders of these efforts. But I think arguably they've really moved the expectations along. So we get to the second decade of NORA, 2006, 2016. 2016 used to sound like a long way in the future, but that's passed. We still have a focus on priority research, both identifying what it should be and conducting it. But we've got an added element, R2P, we call it, moving research to practice through sector-based partnerships is what we decided. By now, government agencies are not only asked not to be wasting money, but they're asked to be proving to Congress that they are meeting their mission. So you need evidence. And in order for a research agency to make a case that we are affecting workers, we need to be working with a lot of different people, with partners who actually have contact with workers. So let me move through these. I've got several examples from the second decade. Well, first of all, the vehicle for a lot of this is the NORA sector councils. I've mentioned them. We defined 10 sectors. I'll list them in the next slide. But the mission, so we had teams in the first decade, now we have sector councils. And by moving to a sector focus, the idea is that occupational safety and health professionals in companies, in universities, but especially in companies and unions, they identify with the sector that they're in. If you're in a manufacturing plant, you're going to have a lot more to talk about as an industrial hygienist with somebody else who's in manufacturing than with somebody who's perhaps in construction. So sectors matter. And so we have been able to attract a lot more industry involvement through the sector approach. So the mission of the sector councils has two parts. One is to write down, to define a sector-specific, a strategic plan for the nation in their sector. What research needs to be done, what knowledge that's already out there needs to be better used, those kinds of issues. The characteristics of these sector councils is that we have broad participation. We invite a lot of people in from different parts of the sector. You have to keep the group workably small, but still it's typically 25 to 35 people. And the participants don't come representing themselves, their company, they come representing the sector. You're a professional in occupational safety and health typically, or you're interested in occupational safety and health, come help us figure out for this pretty broad sector usually what needs to be done. And the other thing is transparency. We aren't doing this behind closed doors. We're trying to have as much on the website and as much openness as possible. So let me list the 10 sectors. We started with 8 and then ended up with 10. And these are actually based, you may not be aware of the North American Industrial Classification System, but the Census Bureau, working with Canada and Mexico, has definitions. I think they have 20 or 22 sectors that they define. And so something like financial services is a sector, construction is a sector. Some of those we've taken over directly, like construction, but we generated this from a view of occupational safety and health and where the major hazards are. And so services has certainly many high hazard subgroupings like lawn care or landscaping professionals, and even arts and entertainment when you think about some of the crazy things and the deaths that have happened on movie sets and circuses and so on. But then a lot of the government employees, schools, a lot of kind of white collar, lesser, more sitting at the desk kind of services. Universities are in the services sector. So actually half of the workers in the United States or more these days are in the one sector, services. So just to let you know, these are by no means equal in the sense of population. Mining and oil and gas extraction, you can get into fistfights about the size of those, especially if they're talking to each other, but that's another story. But they're 200,000 or 300,000 workers each, so they're probably the smallest of the sectors. So those are the sectors, and if you are interested, there is a national sector agenda for each of these on the website. But let me, again, not get off to the side on all the other aspects of NORA and stick with partnerships. So there was a two-part mission for these sector councils: generate a sector agenda for the nation and work to improve the situation for the workers in the sector. So how do you implement? How do you get to the sector councils? Mostly formed in late 2006 through 2007. By 2008 and 9, most of them had sector agendas on the website. So how were they going to move to the next step of implementation or actually making a difference in their sector? And this was interesting, and each sector is quite different, and each sector council has a different personality. But in general, we put out a very general vision, which was you've got the national sector agenda as one input. You have a lot of expertise around the table. Some of the sector councils even reinvented themselves with half or 2/3 of the people turning over to move from sort of the research focus to the getting the word out to the sector focus. But you've got all these other potential players. You can read the list as well as I can on both sides there. And the idea is, again, a focus on partnerships. Let's have a shared vision, shared values, come together about some things we can do now that are going to make a difference. And so if you kind of think about the stages of change model, which I'm actually a physicist. I've never had a class in any aspect of public health, so you know the change model probably a lot better than I do. But basically, I'd say you have to let people know there's an issue, or they have to accept that there's an issue. Next, they have to realize that there are solutions that are feasible. Then they have to move to action and probably have a fair amount of hand-holding or some assistance to actually effectively implement these solutions. And then you get to a maintenance and evaluation and kind of moving to the next level stage. So in general, about all you can say is that the NORA sector councils had the job of picking issues, big, small, whatever they thought was ripe for movement, and trying to move people to the next stage in the model. Do we need more knowledge? Do we need more people to understand what the issues are, and so, or how they can implement them, and so on? So that in general is a real kind of 30,000-foot level of what we wanted to be happening the last 6-8 years of the decade, of the second decade of NORA. So I'm going to have some examples of successful partnerships. Each of them is trying to reduce the risk for workers, but notice that the number and types of participants varies, the approaches vary, the products vary, and the outcomes, or what we know about the outcomes at this point, certainly varies. So that is sort of my, I guess, teaching portion of it, being at a university today. Keep an eye out for those things, and hopefully you'll find something of interest here. So I'll try to move these through these fairly quickly and not have my allergies take my voice away along the line. So being a product and a generator of the second decade, the NORA coordinator, I tend to do things by sectors. So you'll tend to see a sector listed at the top, one of the NORA sectors. And this reminds me to talk about a couple of things that have been happening in the NORA Healthcare and Social Assistance Council. This, I'm going to have to lower my energy level a little bit and try to save my voice. So if you can't hear me, maybe we can work on that another way. One of the big issues, there's several big issues in healthcare. One is violence, and I'm not going to be talking about that one today, but that's a huge problem in healthcare. One is the whole MSD issues around patient lifting and handling, and these are different. Some of these are different aspects of that. And then, of course, there's infection control and a lot of other issues in healthcare. So these are actually 3 examples. On the left is an early example of working with the Joint Commission. Now, if you are involved in a hospital at all, the running or employment in a hospital, you know who the Joint Commission is. If not, you probably don't know who they are. But the Joint Commission accredits hospitals. So they come in every few years and they say whether your hospital operations and facilities are up to snuff to be considered a real hospital, or whether you're in deep doo-doo because you're not doing things the way you should be doing them. So the Joint Commission carries a lot of weight with hospital administrators and employees. And one of the big pushes over the past, I'd say 15 years, has been patient safety. Remember, well, maybe some of you are too young to remember, but been a lot of stories about how many patients are killed due to medical errors, putting it in its starkest terms, I guess. So there's a big focus on patient safety, but it isn't, I mean, it's not just killing people in overdoses and things like that, or giving them the wrong medicines, but it's things like slips and falls, you know, trying to help somebody out of bed and they fall on the floor and break their hip again, or things like that. So by tying, and so that patient safety has had a lot of funding, a lot of attention. It's been probably the major focus of what hospitals need to do better. Or, I mean, the medical world's always changing, but that's been one of the major focus areas. So the Joint Commission, this elephant in the room of hospital administration, was on our council, one of their research members, and they said, we really have become convinced that patient safety and worker safety are just two sides of the same coin, that you can't define a good program for patient safety without having a good program for worker safety, because there are just so many elements in common. Think slips and falls, think safety in lifting patients, for example. So they put together a workshop and an effort to put out a report on improving patient and worker safety at the same time. So this has been a major effort. There's an American Nurses Association, long-standing, large, important. Nurses are so important to so many parts of, to medical care in general. And one of the big problems, besides violence afflicting nurses, is the patient lifting issues, nurses and nurses' assistants especially. So we know there are lifts out there. There are many different varieties. They can be designed in, they can be put on ad hoc later, but they just, kind of got started, and then they really haven't been, you won't find them in most hospitals in every room. At least not when my parents have been there. So the American Nurses Association said, well, we write standards. I mean, we're not a government agency, but we write standards that we want nurses and nurse supervisors to pay attention to. So we're going to write a standard on safe patient handling. Well, they did it the partnership way, and they started inviting people in, and they realized they needed people there from the pharmacy, and they needed people there from physical therapy, and they need people there from all different sides, from housekeeping and engineering and all different sides of the hospital and clinic environment. And when they got them all together, they realized they weren't just talking about patient lifting safely. They were also talking about patient mobility. Again, it's outcome of the patient, of course, is the whole purpose of clinical medicine. So they expanded it to include mobility. You can't just lift patients all over the place if they need to be out and walking in order to get out of the hospital and get home and recover. So they tied together the patient handling and the mobility, and they got all these different professions to agree on basically best practices. So these have been written down, and everybody has buy-in, so it's going back to all these professions, and we're hoping that this is going to result in, again, an integrated safety program for workers and and patients in hospitals and clinical settings. So this was another very large effort. It took probably 5 years. They got into it, you know, it got way beyond just nurses. It got way beyond patient handling only, and I think has come out to a very nice result. The third one, I didn't have a picture to show you, but in dentistry, you know, dentists and hygienists wear gloves. You know, we've seen this change over the past few years in dental settings. And infection risk control is being paid attention to. But the question for this organization for Safety, Asepsis, and Prevention, which is focuses on dentistry, is whether these dental offices really have a full program. Okay, they've got the gloves on, but are they cleaning the surfaces? What needs to be done with the chairs? What needs to be done with the parts of the tools that don't come out of the sterilizer every time? Are they sterilizing properly? Do they have a full program? So they started with the what do we know kind of piece. They did a survey and asked people, okay, do you have a full program? Do you do this, 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 and this, or are you only wearing gloves? And and so that's an early step. It's in dentistry, is fairly small. This organization in NIOSH designed the survey and are getting a paper or two out of it, trying to raise the awareness issue of what some of the best practices are. Well, the next stage hopefully would be to write some full guidelines and try to find ways to encourage these organizations, these employers to use those guidelines. So again, healthcare and social assistance, this is brand new. It was just announced in the last month or so. 19 authors, but I think there are about 40 people have been working over around about 3 years, talking about, again, crossing silos. How do we clean and disinfect effectively and protect the respiratory and dermal health of the workers who have to do this in the clinical setting? So, you know, you can't just ignore the disinfection in hospitals and clinics and so on. You have to do everything well. So cleaning, disinfection, and worker safety and health. So a lot of different people, in fact, Europe and the US, international partnership. They call themselves the Cleaning and Disinfecting Work Group. Their focus is in healthcare, but I think the application will be much broader. Again, there were two kind of champions, two major writers, Margaret Quinn of the University of Massachusetts Lowell and Paul Henneberger of NIOSH. And they have gotten all these groups together who often will focus only on disinfection or cleaning or occupational safety and health, and they've got some best practices in a publication. Whether NIOSH will take that to the level of an alert, I don't know. We'll have to see what happens with all this. The reason an alert, a NIOSH alert, or I haven't mentioned NIOSH criteria document is even a bigger effort. The reason those tend to get people's attention is not only because NIOSH is a federal agency and works nationwide, but we were created at the same time as OSHA, and the OSHA Act, the OSH Act, says if NIOSH delivers a policy document, either an alert or a criteria document or something at that level, to OSHA, OSHA can start acting on that right now. They don't have to go back and re-guess the science. NIOSH did the science. It's done. I mean, the current summary is to be assumed by OSHA to be correct and state of the art. And so OSHA can, you know, take a year or so and mail that alert to all, whatever, 500,000 workplaces that need to know about it, and then they can start citing them. I mean, that's I'm sure their lawyers have a much more difficult process, but that's my overview. So these documents at the alert and so on stage can carry a lot of weight, because OSHA can start citing after, you know, a period when people have learned about what NIOSH has concluded. Again, cleaning. It's been a big issue. You ask people in workplaces what the issues are. It's the dermatitis, and I can't breathe when I'm cleaning, and so on. So this was actually an older effort, probably 3 or 4 years ago, on empowering workers and informing employers that there are some basic steps you can take to effectively clean and not gash your workers. I mean, of course, there's always don't mix ammonia and Clorox type cleaners together and produce chlorine gas, but there are a lot of other things that have been well known. So NIOSH with its partners have created some easy to read sheets with the major messages, have worked with OSHA, so OSHA's name's on them too, and put them in the languages we need for people who are doing hotel cleaning and restaurant cleaning and so on. Tagalog is a Philippine language, which I had to look up at one point. But so this is taking what we know, packaging it, and working with partners to get it to all the employers and workers who need to know it. That's what that partnership was about. Again, the Services Sector Council, the ERC in Berkeley, had created with NIOSH funding a nice set of fact sheets, essentially a whole program for school safety, from bus drivers to mechanics to the custodians and administrators, you know, your overall injury and illness prevention program. So these are very readable, focused on schools. If I'm in a school, I don't want to know what Dr. Michael and OSHA is talking about with an I2, P2 program that he's mainly thinking of construction or something. It doesn't sound like it has anything to do with my workplace, even though it has a lot of similarities. So that's one thing about the sector approach, is we realize the big areas where we need to put it in the language of those workplaces and get it out to them. And then we've gotten some of the first stages of the change model in place, and OSHA can come along with a little stick and say, well, this has been around a long time, you aren't doing it, you're in the wrong. But mostly, of course, the trade associations will pick this up and use the carrot approach of, this is what you really ought to know, it doesn't cost that much, and we need to be doing this. So they took these existing sheets and were able to disseminate it through the unions and the various trade associations associated with education, and that's what that partnership accomplished. Manufacturing Sector Council, manufacturing's a huge part of what NIOSH does, because we really have kind of special powers and special capabilities in health effects, especially long-term studies. So we've been involved with manufacturing for a long time. There's a lot of information on our website, a lot of information out there about the various hazards of manufacturing. So the work that the Manufacturing Sector Council has decided to do is really the dissemination piece. We've got a lot of knowledge of what the hazards are. We have a lot of knowledge about what the solutions are. Let's keep getting that information out there in ways that people will really find that they can act on it. And also working, bringing groups together among researchers, among the occupational safety and health professionals. So you can see they've focused a lot on conferences. They have a national safety conference. The National Safety Conference is a really big thing among large employers. And so they have an ongoing session every year now on research to practice. What do we know that ought to be used more in the field, in workplaces? And with especially focusing on opportunities in manufacturing. They've, I don't know if you've looked at the NIOSH science blogs. Most of them tend to be written by NIOSH researchers, but we're trying to open it up to others. And in this case, there have been a lot of joint or even non-NIOSH people writing blogs on different information, different resources, different successes in getting information out. This example is actually an MSD blog that was a joint effort. Wholesale and retail trade, let's see, I need to be wrapping up. This was an exciting one because equipment manufacturers generating conveyor belts and other things for moving materials safely without breaking backs, hurting backs and muscles, tend to be focused on warehousing. How many times have you walked into a grocery store and seen somebody, you know, down on their knees and reaching way up high and lifting things up and shoving things down on the bottom shelf? So this was an effort to get those material handling equipment manufacturers together with the retailers who said, look, we can't take, your stuff's too wide, we can't fit it through our aisles, and so on and so on. Get them talking and to make equipment that'll actually work in grocery stores. And it's been very successful. Let me just skip through some of these. Transportation, warehousing, and utilities. There's been a lot of press about the health of truck drivers, and some of that's been from the results of this big survey that NIOSH did. Again, with the input of the council that this is something that needs to be done. This is, transportation is a highly regulated industry, and this, wrong one. This is an effort to, this report was actually talking about bus drivers and how to, you know, there are a lot of obese bus drivers, and how to, along with a lot of other issues at their workplace conditions, talking about best practices. And it was NIOSH working with these regulatory authorities who tend to focus on public safety and rider safety, but let's get worker safety in there too. There's some great things that have been going on in the Oil and Gas Extraction Council. Let me just say this is a group that is mostly companies, large companies, but they've really taken this mission of developing information for the whole industry, where there are a whole lot of very small manufacturers or very small companies, contractors, and saying how can we help them improve their safety records. And one thing they came, you know, the safety pays message that we were all familiar with, how do you translate that to somebody who's digging oil wells? So they said, how many days does a rig have to work after sustaining an OSHA reportable injury to cover the total cost of the injury? So it's not only how much your workers' comp goes up, but what about the wages of that worker? What about the effect on the family and all those things? So really trying to get that message across that safety pays in the vernacular of that sector, which turns out to be very important. And another thing the big companies have done is they've let NIOSH come in and they've let their, they've developed some best practices. In this case, well, let's see, when they're moving a rig, they've got big trucks all over and big equipment and broken down. It's getting broken down and put on trucks and just a lot of chaos. And how do you do that to keep everybody safe? And so this is they have allowed their workers and supervisors who, you know, speak the vernacular to say, this is what you need to do, this is what you need to watch out for, these are the best practices. And they've done it in videos. And considering it's a fairly small industry, the download numbers of those videos is actually phenomenal. This is really taking off. And okay, big national prevent falls in construction, especially residential construction. Big effort by the committee, big effort by NIOSH. OSHA came in. NIOSH used its research capabilities to develop the messages. OSHA picked it up and has run it as a national campaign for 4 years in a row now. National stand downs and so on. So it's another huge effort that's taken something like 6 years and now is almost a fixture, an annual stand down in residential construction to talk about how we're not going to fall off the roofs and how we're not going to fall off the scaffolding. Another construction, I don't know if you're probably familiar with new buildings and the LEED credits and platinum building and silver and gold, and you may have heard of some of that. They focused on things like energy efficient light bulbs, energy efficient ventilation, that kind of thing. But NIOSH, at the urging of the Construction Safety Council, the NORA Construction Sector Council, went to this, what's it called, the Green Building Council, and said, what about worker safety? And they said, what? So we worked with them for some time, and now there's a pilot credit up. You can actually move from one level to the other and get a credit for actually building prevention through design into your building. So it takes the architects, it takes everybody, but you'll actually have anchor points up on top of the building for fall protection over the lifetime of the building. And a lot of life cycle issues in the construction, the planning of the building, construction of the building, maintenance of the building, and eventual demolition of the building. You can plan for a lot of this ahead of time and reduce hazards. So that's been a huge effort and has been a success. So we are doing we're doing a management level evaluation of the second decade. We started planning in 2014 and it's coming to fruition. We're collecting data right now and the report should be out in the end of this year or early next year. 3 basic questions: what did we do, how well did we do it, and what was the impact? It involves most parts of NIOSH and a lot of partnership issues that I've been talking about. And it's the results of this evaluation and other discussions that are going on all the time that will determine how NIOSH will structure a third decade of NORA. Is it going to be sectors? Is it going to be something else? Is it some combination? We kind of took what we call the cross sectors, the non-sector side of things. The first decade, we took a pure sector view the second decade, so what are we going to do in the third decade? And I'm retiring at the end of 2016, so one of my jobs is to groom someone else to take over that decade in coordination role. So the big picture, NIOSH uses its national standing to create forums, to set the table, to invite people to the table, and to work in partnerships. And what do we get out of that? What's anybody get out of that? One thing, we promote the importance of occupational safety and health. The people who aren't always thinking about that is their first concern. We do focus research on the priority issues, not just whatever you want to work on, what your lab's equipped to do, but what is needed beyond that. Leverage resources of organizations with similar, complementary, or overlapping missions. Foster partnerships, and ultimately we're trying to serve the worker, but we do want to survive as an organization. We think we're bringing something to the world, and so we want to increase our effectiveness, and NORA and partnerships are one way we're doing that. So most of these partnerships have been written up in a very brief way with typically a website link in the e-news. If you aren't getting e-news, it's very easy to do. Just go to the NIOSH website and you just give them an email address and you can stop it anytime you want. You can go to the NORA website to see the sector agendas. And since nobody but my mom and I can spell Soderholm, you can send a email to NORA coordinator at cdc.gov if you ever want to engage around any of these issues. So I've run a little long. Oh, I've run pretty long. So
you're doing just great, and we do have time for a couple questions, but I'm going to take a management prerogative and ask the first one. I might have missed it, and I apologize if I did, but has there been much union involvement in the sectors, in particular maybe manufacturing or?
there has been to some extent. I would say construction and manufacturing are probably our biggest union involvement. Even 10 years ago when we were setting the councils up, we went to the unions. You know, NIOSH has worked with unions a lot over the years and said, you know, can you send your health and safety person to this? And they said, we've got one and she's busy. So the unions have been hit pretty hard. So there hasn't been as much involvement as we'd like, but we've tried to make sure they're invited everywhere we can. So.
We still have time for any other questions. Go ahead.
Can you talk a little bit about the cross-sector initiatives that NORA has? So I know, for example, I'm personally interested in surveillance and industrial exposure. How do these cross-sector platforms interact with the different sectors?
Well, within NIOSH, and I've purposely not talked about, you know, my own little universe, but within NIOSH, we actually have a sector structure and we have sector programs, and each of the 10 sector programs runs a sector council and is aware of what's going on in NIOSH in their area. And we have cross-sector programs, so it's a matrix. So we have respiratory disease, surveillance, exposure assessment, immune and dermal issues. We have, I think, 24 cross-sector programs. And so within NIOSH, every project is coded to, you know, all comes down to what you can count. It's coded to 1 or 2 sectors and 1 or 2 cross-sector programs, depending on what's relevant. So we do know the importance of everybody working together. You come out of, typically you come out of a university program, you have expertise in industrial hygiene or medicine or something else. You don't have expertise in construction or manufacturing. I mean, it all, you know, but you need all that. So I think one of the, as I said, the first decade kind of took, okay, everything's cross-sector. We have 20 cross-sector teams, as we would call it. And the second decade was, okay, we've got all the workers covered in 10 NORA sectors. We can actually manage 10 sector councils better than 20 teams. What are we going to do for the third decade? And I don't know the answer, but the whole cross-sector approach, you know, how do we keep improving tools in exposure assessment? How do we keep knowledge about respiratory diseases applied to all the workers, no matter where they work? That's forefront in the thinking. So I don't know where it's going to go, but how do you organize something so you can explain it to somebody and make it work? That's the trick.
We do have time for one more question. There's one. Looks like there's one in the back.
So one of the issues is dissemination of information, you know, and I don't know what we have done to kind of address that. You know, we have information, a lot of people are where to look for it, or who to go to.
Right. So information dissemination, big issue, and I think that's where we've opened up a lot of vistas. 20 years ago, when NORA first started, we had mailing lists, and we would send an alert on related to hospitals to every hospital in the country, and there, wow, we're done with our dissemination. And so we've gotten a little better now. Now we have people from hospital associations, you know, nursing associations. They have their mailing lists. They have their advocacy points. They have their trade publications. We're almost, well, we're getting to the point where if you're a NIOSH researcher and you spend time writing a trade publication that gets published in, you know, whatever, Floor Tile Today or whatever it is, you get almost as much credit as if you get a publication in a you know, physiology magazine or, excuse me, journal or something like that. So the overall answer is we can't really do the dissemination to the right people, but we're getting better at partnering with those who have the mailing list, have the ears, and have the newsletters and tools to get information out, and hopefully also to get feedback. You know, what was that about? I didn't understand it. Let's try again, or whatever. So that's kind of where we are in my view. Whoops, I'm sorry, Don, I said, okay.
How do you measure the effectiveness of your program? For instance, do you have metrics such as incident rate for sectors of the economy trended over time, so you can see whether they're improving or deteriorating?
Yeah, that's the big, we have really struggled with that, and research agencies have struggled. How do I measure my effectiveness? And we certainly do have the BLS data and other data and we are drawing trend lines, but we had a series of our programs, sector and cross-sector, go to the national academies and try to document and talk about their effectiveness, and were actually graded by the National Academies Committee. And out of that came an understanding that it's very difficult to take credit for or take the blame if numbers turn the wrong way or go the right way. I mean, there has been a slow decrease in fatalities and injuries and so on across the workplaces in the U.S. for the past 40 years. Sometimes there are nasty bumps and so on, but one of the big answers is that we really can't always go to the end outcome of fewer workers getting hurt and killed. There's an intermediate outcome. So the research agency works through these partners we were just talking about and is able to do things that get to the worker. So what are the intermediate outcomes? Is the research agency really taking the time, the effort, and the resources to work with the unions, to work with the trade associations, to listen and talk and deliver materials to the trade association that can be translated into something that makes sense to their clientele, not just hand them a paper from the American Journal of Industrial Medicine, but a fact sheet or an alert or something in, you know, where we've attempted to get into their vernacular or use their vernacular. And then they can really talk about it in their annual meetings and kind of keep the drumbeat going. Have we succeeded in convincing some of these trade associations that worker safety and health is an important part of their mission in their industry? So these are the kinds of things that and it's more anecdotal. We can, you know, you can count trade publication numbers, you can count some things, but a lot of anecdotal evidence. So NIH, NSF, everybody's been dealing with how do you measure the effectiveness of a research agency, and these are some of the approaches we're using. So.
I think that's a great question and a great answer to a great question to end the session. Let's thank our speaker.